Hello, my name is Dr. Nima Maozoon. We're going to be talking about tools for identification of acute stroke in this discussion. The focus of this is on code stroke. Patients that present to the hospital with symptoms of acute stroke would present to the emergency department either through the EMS or walk in through the triage. Another way that patients are seen in the setting of acute stroke in a hospital setting is patients that are seen as an inpatient stroke alerts. So we're discussing now how to identify very quickly patients that may be presenting with acute stroke. We've historically been using a tool that we've all termed as FAST, which pertains to symptoms of deficits in face, arm, and speech. Specifically, if there is a facial weakness, facial droop, if there's weakness of the arms, or if there is dysarthria or disturbance of speech, or trouble speaking. Those are the three things that come out from the FAST acronym that alerts the providers to activate code stroke. And based on this, EMS has come up with their own tool across the nation, which is essentially modified Cincinnati score, essentially a variation of the FAST acronym, particularly face, arm, and speech. Let's focus for a couple of minutes on why patients don't come to care, and then we'll talk about how the providers on ground can miss signs and symptoms of stroke. Well, on the patient side, often there's lack of awareness of signs and symptoms of stroke. When it comes to cardiac care and symptoms of cardiac illness, the symptoms are mostly chest pain, and the patients know that once they have chest pain, they need to come into care. However, when it comes to stroke care, symptoms are heterogeneous. So patients can have weakness, numbness, double vision, difficulty speaking, and so on and so forth. And because the symptoms are so heterogeneous, it's often difficult for patients to remember the symptoms and to remember to come in when they have the symptoms. Now, the other thing is that patients who have stroke sometimes may not be aware of their symptoms. Sometimes there is a loss of awareness or loss of consciousness, and that can delay patients to come into care. Patients can be found by family members down on ground with loss of consciousness after a variable period of time. And often, patients may not be aware of their symptoms. Particularly with strokes that involve the right hemisphere, patients are not aware of their deficits on the left side. On the provider side, there is several things that we have to be aware of and be careful with. For instance, patients that may be aphasic may look like or they appear to be confused, and in reality they're actually aphasic, and the issue is really with language and not so much with encephalopathy. And aphasia is a sign or symptom of a left hemispheric, left middle cerebral artery stroke. Another thing is that a large PCA stroke can often be missed, particularly when it's on the right side of the brain. A right posterior cerebral artery stroke will give patients a left-sided visual field deficit, but now right hemispheric strokes also cause patients to not be aware of their deficit on the left side. So patients can have potentially a large right posterior cerebral artery or right occipital lobe stroke and not be aware of their visual deficits. So they won't come into the care and they won't be stating, I have a left-sided visual field deficit, but rather they may say something more generalized, such as my vision is blurred or I can't see well, and something like that. So as a provider in triage, it behooves us to be cognizant of that and identify those patients very quickly by quickly doing a visual field exam as a screening tool, as part of your screening tool in triage. Or if you are the EMTs that are seeing the patients on scene, same thing. The other pitfall is patients who are ataxic. For example, patients may present with a history of fall, and they may not really present a history of ataxia or imbalance. And what happens is the EMS may be activated. EMS will bring the patient in a stretcher. The patients are transferred from the EMS stretcher to the ED stretcher. And then from there, they're transferred to the stretcher that transports them to their room after they're admitted. And sometimes, in the mayhem of things, patients don't get walked, and the gait examination can be missed. So it's important to have a screening of their gait as part of the initial assessment. Another pitfall on the provider side are the posterior fossa strokes. Oftentimes, patient presents with dizziness and with nausea. So the two most common signs or symptoms of cerebellar strokes are dizziness and nausea. In that case scenario, dizziness may mean a lot of things, but getting the right history and doing the right screening to identify if dizziness means lightheadedness or ataxia or something else would be important. If the patients are ataxic and they're nauseous, then cerebellar strokes would need to be a consideration. Let's talk very briefly about the different lobes of brain and how that pertains to this initial assessment. The frontal lobe is responsible for motor function. The motor cortex is in the very posterior aspect of the frontal lobe. If a patient has a frontal lobe stroke affecting the motor cortex, they'll present with motor weakness on the other side. The parietal lobe is responsible for sensory function. The sensory cortex is in the very anterior aspect of the parietal lobe. If a patient has a parietal lobe stroke affecting the sensory cortex, they'll present with sensory loss on the other side. Occipital lobe is responsible for visual function. So if a patient has an occipital lobe stroke, they'll present with visual field deficit on the opposite side. Now, language function is spread from the temporal lobe and spreads through fascicles of nerves into an area in the frontal lobe called Broca's area. Now, let's talk a little bit about what's called homunculus. Homunculus is a representation of the body parts, the motor cortex and sensory cortex. So motor cortex, we talked about in the frontal lobe, posterior aspect of the frontal lobe, sensory cortex, and the parietal lobe. The homunculus is a representation of body parts as it pertains to these two functions. So as you can see here, the face and the hand are represented in a larger part of the cortex, both motor and sensory, than the upper part of the arm. And really the reason for that is there are more sensory nerves and more motor nerves that innervate the head and the hand. There's a lot of different muscles that are responsible for fine motor function, and there's also a lot of sensory nerves that innervate the palms and the soles. And so our most sensitive parts of our body are the palms and the soles. And for that reason, those nerves have to be housed somewhere in the brain, and so they end up occupying a larger part of the brain. And same thing in the lower extremities. In the lower extremities, the foot has a larger amount of nerves and innervation, both sensory and motor, than the other parts of the lower extremity. And so it will occupy a larger part of the brain necessarily. And so it's more common for patients to present with facial weakness and hand weakness as a sign of stroke as compared with arm weakness. One never sees a patient presenting with biceps weakness or deltoid weakness or triceps weakness as a sign of stroke with a completely intact hand function. So we thought of a new tool that would take the place of the FAST, that this is incomplete and it will miss a lot of patients that have symptoms other than facial weakness, arm weakness, and disturbance of speech. We use the acronym and the tool SAVES. S for smile, A for arms, V for vision, E for even balance, and S for speech. Now let's get into this. S stands for smile. Patients that present with an asymmetric smile should be considered for possible stroke. It's important to note that patients that present with cortical deficit that will affect their smile, that will affect their facial muscles, will often present with asymmetry of smile and weakness in the lower aspect of the face. On the other hand, patients that present with facial weakness because of Bell's palsy or something else that's peripheral, they will present with weakness of both the upper and the lower aspect of the face. When in doubt, call a stroke alert. A stands for arms. Here, what we're looking for is sensory function and motor function. And a quick screen is to look for drift. Here, what we would ask the patients would be to hold up their arms and supinate their arms in this fashion and close their eyes, and you would wait for 10 seconds. You would have to wait for 10 seconds or until you actually see the drift. When patients close their eyes, they may have a slow drift of their arm downward and pronate their hand a little bit. That's called pronator drift. Perhaps a more sensitive way to check for drift is what we will call extensor drift, where we ask the patients to hold their arms up, palms facing down, and also ask them to bend up their fingers. This will make it a little bit more sensitive way to test for pronator drift. Once again, ask them to close their eyes and wait for 10 seconds. If they have a very slow drift of their fingers, that's usually real, and that usually will signify a cortical stroke. So vision pertains to diplopia. You would have to ask the patients, do they have double vision? And if they tell you they have blurred vision, that may still be small amount of double vision that may look like it's blurred. So you really have to ask the questions. Now, if there is a visual field deficit, remember that visual field deficit is really a brain problem, meaning that they will not be able to see their left or their right visual field, meaning their environment. So patients may say, I can't see out of my left eye, but what they really may have is a visual field deficit on the left side, not so much the left eye. So to test the visual fields, you would have to put 1 or 2 fingers up for the patient and ask them to tell you how many fingers they see. Sometimes we have the patients cover one eye or the other, as you can see in this picture. However, a better way just to assess the patients in the triage or screening setting would be just to have the patients look at your nose, so they're focusing on an object, and then put 1 or 2 fingers on the side. Now remember that if your fingers are too close to the patient, they're not going to see your fingers. You're going to be in their blind spot. So you would have to make sure that you're putting your fingers, as you can see on this picture, in between you and the patient. So take that distance, cut it in half. You should be right there in the front. Put 1 or 2 fingers and test upper and lower quadrants on both sides. So the E is for even balance. This pertains to the patients that are ataxic. Patients may come in with a gait and a stance that may be wide-based. So patients will spread their legs in order to maintain that balance. And you may see a little bit of a staggering and a little bit of a correction of the torso back and forth as you're testing their gait and their stance. That wide-based gaze will signify ataxia. Now, S is for speech. Now, remember that speech pertains to 2 things. One is dysarthria, the other is aphasia. And remember that aphasia is a dysfunction of language, which means that patients will not be able to name or repeat, whereas dysarthria pertains specifically to trouble with articulation. Now remember that aphasia is a disturbance of language, which means that it pertains to both written and spoken language. In the earlier part of the talk, we alluded to the centers that are responsible for language function. Language function starts out in the temporal lobe, superior temporal gyrus, and ends up in the frontal lobe, the very bottom part of the motor cortex, specifically Broca's area. Those are the components of the brain that are responsible for language. Temporal lobe and the frontal lobe. Temporal lobe is responsible for understanding language, for comprehension. Frontal lobe is responsible for articulation. So if you were to ask the patient, repeat after me, no ifs, ands, or buts about it, comprehension occurs in the temporal lobe, in an area that's called Wernicke's area. And there are fascicles of nerves that carry that message to the frontal lobe in an area that's called Broca's area. And so if you were to ask the patient, repeat after me, no ifs, ands, or buts about it, they will first comprehend that spoken language in the temporal lobe and Wernicke's area. The message is carried through nerve fascicles to the frontal lobe, where the patient will carry out the motor function of articulating that command. And that area is called Broca's area. So to examine language function, we really are examining fluency and comprehension as part of the language exam. So an MCA stroke that predominantly affects the Broca's area, those patients understand well, but they can't get the words out and they're very frustrated. Whereas a stroke that predominantly affects the temporal lobe, specifically Wernicke's area, those patients will lack the comprehension but are able to articulate with fluency that seems to be relatively intact. Those patients have what's called Wernicke's aphasia. The speech is lacking grammar, but it's fluent. And both kinds of aphasias have difficulty with naming and repetition for the most part. For the purposes of triage and screening the patients for aphasia, we would want to focus on naming and repetition. So have them repeat words: mama, tip-top, 50-50, huckleberry, words that are in your NI stroke scale, or have them repeat a sentence such as no ifs, ands, or buts about it. Or maybe a sentence that's a little bit longer but catchy, like she came home in a blue Cadillac in a flood of tears. And for naming, we would be using the NI stroke scale pictures to ask the patients to name. That's very, very important to distinguish patients that are aphasic from the confused. Now remember that aphasia is a disturbance of language. All patients with aphasia will have trouble with naming. Patients with Broca's aphasia and Wernicke's aphasia will have difficulty with naming and repetition. Patients with Wernicke's aphasia will have difficulty with comprehension. Patients with Broca's aphasia will have difficulty with fluency. And this will circle back to our assessment tool, what we call Level 1 assessment tool, which is really the recapture of the SAVES acronym into a tool format that you can use to check off. As you're doing the Level 1 assessment, as soon as you discover the patient has a sign or symptom that meets one of the criteria here, you can stop the assessment and bring the patient to care immediately. Today we've reviewed the use of the SAVES acronym and the initial assessment tool based on the SAVES acronym for identification of patients that come to care through triage, through EMS, and patients that get acutely ill with signs of stroke on the floors. Thank you very much for your attention. This is Dr. Nemo Malzoun with TeleSpecialists.